So Amber, you have Doug Ray, myself, Faria Frid, and David Pecker at
Excellent.
your mercy.
Lee, can you let me share my screen, please? Otherwise, we can just, if you have my, oh, here we go. Perfect. Here we go. All right. Perfect. Okay, well, you see all our panelists, and thank you all for participating in this panel. So what I wanted to do was sort of help kind of go through with the panelists some the kind of keys and pearls on how do you really maximize your success rate after revision surgery. So the first thing I wanted to sort of start out with was the fact that revision sinus surgery is still relatively low, luckily. So that might be a little bit confusing because a lot of people have talked about recurrence rates being higher. And yes, that might be true, but those that actually have to go back to the operating room, these two studies that have just been published in the last year, one from Utah where they had over 10,000 patients that they followed, and another one from Oregon, from Tim Smith's group, basically report similar revision rates of about 15 to 25%, with 25% being those with nasal polyps. So how do we maximize what we do when we have a situation where there's revision surgery? So the first sinus case that I wanted, or the first sinus that I wanted to address and get the panelists' input on is, the maxillary sinus. And I think most of us, because that's where we start our training, is, with the maxillary sinus. And so it seems to be that you would think it'd be a really easy sinus to address, but we're realizing that that's wrong, right? We talked about this yesterday about the natural ostium being not dependent, and some of these, making sure that you really get the entire uncinate. Otherwise, you can obstruct the frontal sinus or have continued problems with the maxillary sinus. And then earlier today, Dave talked about the odontogenic source. And if that doesn't get recognized, then there lead to continued surgical failures. So some of my pearls that I'll just talk about briefly is that, really utilizing angled scopes to get a good visualization, making sure you have the continuity with the ostium and the antrostomy, making sure that you get the entire uncinate out, addressing the odontogenic source. But I wanted to sort of highlight something that was introduced relatively recently from Peter Luong's group, and this idea about megaantrostomy, right? So this patient you're seeing, they come in with a persistent problem, and they've already undergone a typical maxillary antrostomy. When or do you ever consider what's called a megaantrostomy? So I'll get the panelist input here shortly, but I'll start it out with a case. You guys can see it here, a 65-year-old lady. She's actually a principal at an elementary school who had undergone a previous left maxillary sinus procedure for CRS without nasal polyps because she was getting these recurrent infections from this sinus cavity. In fact, she'd gotten so many infections that her, of course, never send a patient to infectious disease, at least in my experience, but they put her on IVIG and that didn't work. She had multiple courses of antibiotics and that didn't work. And so she comes to see me because she continues to have these recurrent infections. And I think you guys can see the film here, but this is what she looked like. Any comments from the panelist? Dr. Farid, any thoughts on that scan?
So in the anterior slices that we were seeing, the uncinate process was actually still intact and not connected to the surgical antrostomy. So I think the uncinate process has to be revised and removed.
Yep, and then I don't know if you noticed back here this little inferior component here, and it sort of is kind of walled off posteriorly, and it was has this like edema around it. I don't know if you guys can appreciate that there. So I saw this and I thought about it because I agree that there's still that residual uncinate, but why is there a possibility that there might be something else going on as well, as I prepared to think about going back in and talking to her. So this is the second paper from Peter Luong's group. The first one was just the initial 29 patients that they had done what's called a mega antrostomy. So they report here a follow-up where there has now a bigger series, 163 mega antrostomies. And they have a follow-up ranging from the initial cohort of almost 7 years to now a 2-year cohort, a 2-year follow-up for another additional almost 100 patients. And basically, they report that 75% of people almost had improvement with undergoing this mega antrostomy, not having to have another sinus surgery or having their symptoms resolved either from Lund-Mackay scores or Lund-Kennedy scores, nasal endoscopy, or a follow-up CT scan. So I'm just going to go down the road, or down the panelists, and get your ideas about this. What exactly is a mega maxillary antrostomy? Greg, what are your thoughts about that? What is the definition of a mega maxillary antrostomy?
This topic was just discussed on Doc Matters, if anyone follows that. And again, no one has come together, no consensus group has really come together to define one versus the other. I'll answer that question, but I do want to go back and say if ID did put this patient on IVIG, it's hard to get IVIG approved because it's so expensive. And that likely meant that this patient did have low immunoglobulins. And if they did meet the criteria for CVID, that's something to, that's an important factor.
Good point.
Back to your question about whether or not it's a mega where you're taking off a little bit of the inferior turbinate and doing the maxillary os all the way up to the nasolacrimal duct and all the way posteriorly to the posterior maxillary wall. Some would consider that a mega antrostomy as opposed to a medial maxillectomy where you're taking the middle third of the inferior turbinate completely out and taking the medial wall of the maxilla down to the level of the floor of the nose. And then you can and then take it, and just as we did in the lab yesterday, take it anteriorly below the nasolacrimal duct.
So when you think about these cases, Greg, do you do a mega antrostomy or do you do more of a medial maxillectomy?
If I'm going to do a larger antrostomy, I'm going to do a endoscopic medial maxillectomy. And a good patient for this would be someone with primary ciliary dyskinesia or cystic fibrosis, or just a really awful chronic infected sinus that you can't get out, and you need to do serial debridements in clinic, and it very much facilitates serial debridements.
Doug, any different thoughts on that?
No, I agree with Greg. I think the idea is you're trying to establish gravity drainage. You've sort of thrown up your hands and said to yourself that the cilia and the sinus are never going to be able to get the debris or the contents of the sinus out through the natural ostium or out through whatever antrostomy you've made. And so now what you're trying to do is establish gravity drainage. And with the hope that rinsing things with irrigations and gravity, you'll kind of start to clear the sinus.
And David, or any thoughts on, is it successful in your hands? Or Farah, I don't know if you've done any of these mega antrostomies. Do you feel like it's successful? When do you think about utilizing this procedure?
So I use it mostly, like Greg said, for CF. I only have a couple primary ciliary dyskinesia patients, and I've done it on them as well. To answer your first question, what's the difference between a mega antrostomy and a medial maxillectomy? In my mind, I see the mega antrostomy as a lesser degree than the medial maxillectomy, but from a practical standpoint, I'm probably doing the exact same thing either way. I will, just like you showed in the lab yesterday, I take the middle third of the inferior turbinate, I will take the medial wall all the way down, I'll take a backbiter and come anteriorly on that medial wall and try to get it as open as possible. And because particularly the CF patients, again, those are the patients that I'm doing this on, have that thick, gross stuff, and the bigger the opening, the easier it is to get that out.
Yeah, I agree. So just because of time, we'll move on. But I did end up doing a maxillary antrostomy on that woman, and there was a little concavity along the floor that really, she couldn't get the medical therapy into it, and I think it really required topical access for her, and that really helped resolve a lot of these recurrent infections there. So let's move on to the ethmoid sinuses. And I talked about this yesterday, that this is one of the more complicated sinuses because in other sinuses, you're really just addressing the opening, right? The frontal, you're really just addressing the ostium, the sphenoid, also the ostium. But the ethmoid, you really have to address the entire sinus cavity. And there's multiple bony partitions. The fact that the lamina and the skull base and that different variations in the sloping may make it difficult to make sure that you get everything out. And so some of the things that I utilize, and I discussed a little bit, but when you go posteriorly utilizing a pediatric 45, I tend to find that that instrument helps me do more finer dissections, especially along the skull base. And then using a mushroom punch along the lamina helps me to carefully remove partitions off the lamina. And then we talked about the sphenoid ethmoid cells and realizing that, and then understanding the trajectory. But one thing that happens often, and I wanted to kind of discuss this is something that we addressed a little bit yesterday, was this whole osteitis. And what do you do about that, right? A lot of your revision patients do come in with this osteitis, and you can see here on this CT that you've got a lot of bony growth. So I'll start with Doug. I can't see you guys anymore, but Doug, how do you see this often, and what are your thoughts on addressing this osteitis?
I mean, that's a really good question. I think it partly depends on whether it's in the setting of an infected sinus versus an inflamed sinus. So if you're talking about a patient with CRS with polyps or hypereosinophilia that just has thickening of bone from chronic inflammation, I'm less, I feel it's less critical to drill out and remove all the bone because it's a product of the inflammation. In the setting of someone who's chronically infected, I would worry that that's a nidus of infection. And you know, this is just one cut on a CT scan, but if that bone is sitting in the middle of an infection in the middle of the ethmoids, then I would want to take that bone out and drill it.
And how can you tell that it's infected? Is it just because you actually see pus or discolored mucus?
If you see
that differentiation,
if you just see inflammation but not pus or thick mucopurulence or other signs of infection, then it's just probably non-polypoid CRS. But if you see active infection, you get cultures, you find pathogenic bacteria, then I'm more concerned that it's a nidus of infection.
Amber, this is a great case, and as much as I love doing sinus surgery, I hate these cases. These ones, especially, I mean, you picked such a good shot to show because you're looking at this, and you can see superior to that osteitis, there's an area that's opacified. And you just don't know. And it's always right next to the skull base or on the skull base, and there's a little pocket inside that, and there's no MRI that will show you if that's infection versus inflamed tissue or old scar tissue, gristle. And a lot of times you just, especially if it's matching up with the patient's symptoms, you just have to go in there and drill it down and see what's in there. And I would say more often than not, it's just reactive granulation tissue or scar tissue that's up there. It's more uncommon, I think, to it's less common to find purulence.
Well, so what's interesting, in just last year, Harvey's group put out a very nice review, actually, in, I think, Currents of Allergy and Asthma. I can't, or maybe it's Oto Clinics. But anyways, it's Harvey's group if you're interested, or I'd be happy to share it with Greg and who can send it to everybody else. But it was a nice review going over osteitis. And one point that you brought up, Greg, was that actually the presence of osteitis seems to correlate with disease severity, meaning that it's associated with those patients with eosinophilic CRS with nasal polyps, but it does not correlate with clinical severity. So exactly your point is that if they're not having clinical symptoms, even though you see this, you may not necessarily need to drill this. Another point that came out of their review is that, you know, once upon a time, there was all this discussion about this being infection. I think, Doug, you brought this up, was that, you know, if this is an infection versus inflammation. And at least right now, although there's not great literature on this, it tends to be more of an inflammatory process, maybe associated with the periostin, which has sometimes been associated with CRS. And so they talk about not necessarily antibiotics or needing antibiotics, but more really addressing the inflammation. So, David or Farah, do you guys have any thoughts about when you are really aggressive at getting all of this osteitic bone out versus letting it be and maybe utilizing something else to address this?
So I was going to, even before you made that comment about the Harvey review, I would agree with your last statement, and don't poke that skunk or don't poke that bear. I think that you can make them symptomatically a lot better by not getting that out of there. I agree with Greg. These are tough cases, and I dread seeing that osteitis right there along the skull base and the lamina. And so I will give them the benefit of the doubt, and I will open up everything I can and leave that osteitis alone. And it's only then, if they declare themselves and prove to me that needs to come out, would I take them back and drill that.
I
So,
agree with him.
Farah, well, let me ask you something, Farah, then. Given that we talked about that this seems to be more of an inflammatory process and that we're not going to necessarily drill unless we have to get to a certain spot, would you consider doing something different in your post-operative care, maybe keeping them on steroids longer or putting some sort of steroid-eluting stent in there? Maybe that makes a difference. Do you take those kind of considerations when you think about the post-operative medical therapy?
I still would put them on a budesonide irrigation regimen. I would be a little bit hesitant to put a steroid-eluting stent just because I know they're prone to developing osteitis, so I wouldn't want any foreign body in there to cause more inflammation and more osteitic changes. So I would just have them just do budesonide irrigations, and I would just have them do it for a few months. I wouldn't. I would make sure that they know they're going to be on it for a while. I wouldn't just be in a rush to get them off of it.
What about the other three panelists? Any thoughts on would you change your post-operative care because you see someone with osteitis?
Probably not.
Okay.
I now put all of my post-op patients on budesonide irrigations, even if they don't have polyps, just for a month or two. So that's going to continue.
So just out of the review, it was interesting when I was kind of getting prepared for this conversation. So they did talk about maybe considering longer-term oral steroids. Of course, now we have to keep that in light with what David just talked to us about and all the potential complications associated with that. But, or either trying to come up with some mechanism of delivering steroid better into the bone, because obviously the penetration into the bone is not going to be as good as the mucosa. But there's definitely a huge gap in terms of our management, which is this whole osteitic process. So I don't know if we came up with any answers for everyone, but this is obviously something that we have to deal with often in terms of revision surgeries. Any other thoughts on that?
Yeah, we have a question from the audience. Doug?
Yes.
You can click your clicker, your speaker. Your speaker works if you want to find the button and.
So in the mastoid, we come up with this a lot. And you'll get osteitis in the mastoid, and it looks really not so good on the film. Then you go up and push it, you scrape it, it's pretty solid. And, honestly, it would incline me more often to put a tube in the patient where I normally would just provide ongoing drainage and ventilation, and would probably, in most patients, prompt scanning a year, or if it's asymptomatic. Is there any thought of you would scan these people more often and follow C-reactive protein, or you just not worried about it?
So Amber, I'll repeat the question so you can hear. Doug's question related to making an analogy with inside the mastoid. I think that's in the head somewhere. And they see that it's commonly, if you try to curette it or mobilize it, it's hard bone. Similar to what we see, this reactive bone, it's not the nice spongy bone that kind of flakes away. It's always pretty hard. You would have to drill. His question is, should we be imaging these people? And I think the short answer is, as long as they're doing better and
Right.
healthy and not symptomatic, there's no reason to CT them. But to David's point, very, very good point, and I think now we all agree with what David would do, probably is, do the surgery without addressing that reactive osteitis. And if they declare themselves after opening up every sinus and they're still infected, then you need to go after that.
Yeah. All right, so let's move on, and we'll maybe catch additional questions at the end. So now I wanted to address a sort of an extension of what we talked about, which is to look at now the sphenoid sinus, though. And, here are some of the typical issues that happen with the sphenoid sinus. But osteitis back here is a really big problem, I think even bigger than the ethmoid sinus. So here's a lady that I saw recently, a 60-year-old, who presents with this left-sided sphenoid who had undergone a left-sided sphenoid sinusotomy before seeing me, but she continues to have this persistent vertex headache. And so here's what we see. And again, kind of extending on what we talked about here, what are some options that you would consider with this one? And I'll start with you, Greg. What are your thoughts? What would you do for this patient?
I would drill it out and I would open it into the right side.
Okay. Any other thoughts?
No, that's exactly what I was going to say also. It was described by Don Lanza in the very first issue of, not Lanza, Leopold in the very first issue of IFAR. It's like a sphenoid Lothrop. That's exactly what I would do also.
Doug or Farah, any other thoughts?
100%. And in fact, I whispered that to Greg. I would marsupialize the bad. That patient has a healthy right sphenoid, so marsupialize the left into the right. I do it like a pituitary approach. I do a posterior septectomy. I drill out the whole rostrum of the sphenoid and take down the inner sinus septum. Obviously, not drilling out the lateral.
So that's exactly. Perfect. So I feel like I planted you guys out there, but that's exactly what I did was create one big cavity and try to drill out the other side and then connect it. Now, what's interesting is I've done so she did great and she continues to do really well. I have another person who I've been dealing with the exact same story, but the opposite. The right side has this chronic osteitis and these little pockets of like mucoceles throughout her sphenoid sinus. I drilled her out once and then and marsupialized it, but now she's coming back with these headaches still. And it was only within about 2 months ago. And so I can't imagine that it's already reaccumulated. However, that's possible. I'll probably get her a repeat CT scan. But on nasal endoscopy, it definitely looks like some of the osteitic bone or regrowth is coming on. And so even marsupializing it hasn't been completely successful, or I'm concerned that it wasn't completely successful. Have you guys had that issue? And if so, do I just go back in and just drill her again? Or is there something else to do? Thoughts? David, I haven't heard from you on that last.
Oh, okay. I think it depends on symptoms. If the patient is doing well and asymptomatic, then I would probably just kind of monitor. But if the patient's symptomatic and having issues, then I probably would go back in and revise.
Yeah. What have your success been with creating these common cavities? Has it been pretty successful for you guys?
Yeah, I mean, I haven't had to take one of these patients back yet.
Okay. But theoretically, you could see how like that left side on this patient that I presented may, create yet another mucocele if there's no new bone growth that may be causing her symptoms. But so I've only done it on, I think, 3 patients. And so far, 2 of them have done well. And this new one, I don't know if it's just too soon from surgery or whatnot. That she's kind of acting like she's having recurrent symptoms. But I'll also get a neurologist just to make sure that her headaches aren't from something else. Okay, so I talked about considering removing the inner sinus and creating a common cavity. So let's move on to the frontal sinus. The frontal sinus, as we all talked about, and I'm sure that I didn't get a chance to hear Alex's talk, but this is the one that we all sort of vex about because this tends to have problems that more commonly to like stenosis or closure. It's technically more challenging. And then the middle turbinate does serve as the medial border. And so if we don't address that, that can also close off the frontal sinus. So those are the things think about. And so some of the things that we sort of talked about yesterday already was, really stabilizing the middle turbinate, using, if you feel like there's some areas of denuded bone, in that frontal sinus, consider using maybe a steroid-eluting stent. That has seemed to help me when I'm concerned about scarring down because there was more trauma than I'd like to see left there. I put a steroid-eluting stent, and that has helped keep those open. And then, of course, making sure you take out that superior portion of the uncinate. So I'll start with this woman, a 51, when we talk about the frontal sinus, a 51-year-old female with AERD who has undergone previous sinus surgeries, and your typical AERD patient who's done a procedure in 2011, 12, and 13, even before coming in to see a rhinologist. So this is what you see here. You see that she's had some sort of already opening of her frontal sinus. This is on the right-hand side, but looks pretty, pretty small and kind of at risk for scarring. Clearly, she had undergone a draft 2B, meaning that the anterior aspect of the frontal, the middle turbinate has been resected, but she still has this closure of this this frontal sinus. And so we can see here on her CT scan, and Greg, I think you've seen this patient that I presented earlier, so you can't comment, but here is her frontal sinus here sagittally. So let me just talk to, let's start with David. David, what are your thoughts on AERD patients and your thoughts on addressing their frontal sinus? Is this something that, there's some discussion about proceeding with a more dramatic or more opened procedure like modified Lothrop? Or do you still go through the stages depending on whether or not you have problems?
So this is a tough problem. I think that doing a draft 3 on her would be very reasonable to do. I don't know how successful it would be long term. I have just really struggled with my AERD patients, and for me, the only thing that has really worked well for them from a symptomatic standpoint is aspirin desensitization or the biologicals. Mm-hmm. So I would probably talk to her about all 3 of those and make sure that she's aware that it's not that those options are not mutually exclusive, meaning that we could try one thing and that may not do it, and we may need to try something else. But I would really worry about, even if the draft 3 healed beautifully, I think the inflammation would probably negate the long-term benefit from it.
Interesting. Okay. What about you, Doug? Would you, in your AERD patients, let's say she came to you and she hadn't had any surgery, do you consider an initial draft 3, since she most likely will need at least 1 surgery, and then consider some of these other options that were brought up by David? Or you just do your regular procedure and knowing that they'll probably end up on, let's say, a biologic or whatnot?
Well, I don't think I would do a Lothrop on the first try, but for this patient with multiple revisions, 100%, I would do a Lothrop. But remember, it's not just the Lothrop. You have to do some type of additional therapy, like David mentioned. 100%.
Exactly.
Like, you need all the help you can get with these patients.
Farah, any other thoughts about what you do with your AERD patients?
I think this is a patient that I need to set realistic expectations with, which is kind of what Doug and David both were saying. And I think it's important for them to kind of know their surgical options and their medical treatment options. And I think this is where you really need input from a good allergist and immunologist, and let them know that's part of their treatment plan. Like, not one modality is going to fix everything. So.
And Greg, any other thoughts on, frontals and AERD patients, or one that based on a CT scan that they're going to be small, even if you get a big opening? How do you think about your frontal sinusotomies? How do you approach them? Is it always a kind of a step fashion, a draft 2A, then a 2B if they fail that, and a modified Lothrop? Or do you think about the type of patient, and then that's how you tailor your choice?
I do approach it as a stepwise approach. If there are some cells in the frontal ethmoid system that can be removed, or some scar tissue that can be removed and opened up, and I can increase my chance of keeping it open with using a steroid-releasing stent, as well as budesonide irrigations in the head forward position, and really reinforce that on the patient so it does penetrate the frontal sinuses. I'll usually offer that to the patients and say, if this doesn't work, worst case scenario, we go back and we do a drill out, which does entail a much longer recovery, more symptoms with the recovery, more need for debridements, but that's an option. And I haven't quite bought into the Australian slam of taking AERD patients to an immediate upfront draft 3. I'm just not there yet because we have had a lot of success with doing good, thorough traditional sinus surgery coupled with appropriate medical therapy.
I completely agree. But in this situation where she's already gone through 3 different surgeries and already is at a draft 2B, I did end up, because most of her recurrence was up in the frontal area, that I did proceed with modified Lothrop for her. And this is the cavity that you can see a couple of months after the surgery. This is her ethmoid sinus on the right-hand side. And then you're going to be looking up into the frontal here now. So you can see here's the right frontal, and then the on the other side, going up into the left side for her. And so she's done well symptomatically, but I agree that is not necessarily required. And I don't do them up front in my AERD patients until I can get some better data for that. So with just a minute left, or at least that's what my timer says, I wanted to open it up for any questions in the audience.
Amber, can I ask you a quick question? What post-op therapy did you put that patient on? Because that Lothrop cavity looks fantastic.
I think oh boy, it's been a while since I did her. So the one thing that I've gotten better success with is after doing these, because I trained with kind of the Frank Kuhn lineage, and they do not like the draft 3s because of all the scarring. And so I didn't really do a lot of draft 3s when I was in training, and because they would scar down what I would see. So these steroid-eluting stents have really helped keep them open for me. And then afterwards, I usually just do, budesonide irrigations. I was using the drops, the steroid drops, eye drops for a while, but now I've switched those all over to Xhance, the delivery mechanism that kind of goes up into the frontal, and that sometimes works. But I pretty much just play with it and see which ones keep the cavities open. I don't really think that I have a go-to solution.
All right. Well, thank you very much, Dr. Luong. I really appreciate it. Always, you have great panel presentations, and thanks for joining us from afar.
No problem. I'll be back in about an hour.